As people are still joining, I would like to thank the planning committee who came together to plan this and our fall series. Barb Cavilius, our Regional Stroke Education Coordinator, Stefan Paliuso, our Regional Stroke Program Director, Eileen Britt, the Central South Regional Stroke Community Rehabilitation and Community Coordinator, Stephanie Russell, the educator, clinical educator on our stroke unit and our neurosurgery unit, Leanne Hammond, district stroke coordinator for Niagara, Amy DeHook, our stroke care coordinator at Joseph Brant Hospital, Shauna Croker, who is our educator at Brant Community Healthcare System, Carmen Karmazam, who is our learning facilitator at our Regional Rehabilitation Center, Chris Pollard, who's the manager from Hotel du Shaver, and Tammy Tebbett, our district stroke coordinator. So thanks everyone for helping to put together this great agenda. Barb, it's not advancing.
I can't, oh, there we go.
Sorry. So thank you. Really our objectives for this afternoon are really to provide an overview of the stroke mechanical thrombectomy and review the hyperacute guidelines, to discuss some of our patient experiences and some of our metrics related to mechanical thrombectomy, and at the end of the day to really discuss some new best practices related to our expanded window, and also to talk about some of the new and emerging hyperacute research that's on the horizon. So it is my pleasure to welcome David Dawson, who is our first speaker for this afternoon. Dave comes to us, he had 28 years of law enforcement. He retired in 2015 from the Niagara Regional Police Services and is now working as a private consultant. David had his stroke in 2019 and is going to share his experience with us as we move forward. So I will turn it over now to Dave to really share his experience.
That's great. Can you hear me now? Can you hear me?
I can hear you, Dave. How's everybody else? Can you hear Rhonda? Can you hear Dave?
Yes, I can.
How's that?
I can hear.
Perfect.
Everybody can hear me. Okay. Great. So I'm really pleased to be here, to be asked to talk about this. This is something I think, you know, is very personal to anybody that has this kind of medical thing happen. And but I've been given a second chance, and I'm a strong believer in, you know, I think if you get a second chance, you should really use that second chance the best way you can. And that's by giving back to others. So I had a phrase here that somebody gave me that said, maybe you went through it and survived just so you could help someone else make it through. So that's my theory on why.
Dave, I think you might have gotten muted.
Yep.
How's that?
Good.
There you are.
Better now?
Yep.
Anybody hear what I said? Anyway, I'm thrilled to be here today, and I'm thrilled to say that, you know, being given a second chance in life is very important. I think that you take that and are able to give back. So I was thrilled to be asked to talk, and I know this is a training session, so I'm gonna do the best I can to explain kind of what happened to me and some of the shortfalls. And I don't know if you heard this or not, but somebody gave me this little phrase here, and it said, maybe you went through it and survived just so you could help someone else make it through. And I think that's the theory that I'm going with. That's why I'm here. So my story, started back on May the 19th, 2019. You know, I'm a pretty healthy person, and I had some history of diabetes, diabetes 2, and you know, I was a little overweight, and you know, I had some pre-existing things now that you look back on and say, geez, you know, okay, so there was some reasons maybe that this was happening. So what happened on the 19th of May? I got up in the morning around 9 o'clock, and the first thing I did is I went into the shower. And while I was in the shower, while I was almost done, things started to change my vision, and it was very noticeable on the tiles on the wall. And they started to go crazy. They were just all over the place, and I didn't know what was going on. And at the time, I just thought, well, you know, maybe I'm hungry. Maybe I should just get something to eat. Maybe I'm just dizzy. I didn't know. So I managed to take a few minutes, and it took, you know, 5 or 10 minutes. I collected myself, and I seemed to go back to normal. So I continued on my day. I had breakfast, and then later on in the morning, I went out in my truck. I went down to see my daughter, which is about a 15-minute drive. And coming back to my house, I started to feel tired. I just seemed extremely tired, and I couldn't understand why. So I thought, well, I'm going to go home and lay on the couch. I got home about 2 o'clock. And while I was in the den of my house here watching TV, the phone rang, and it rang about 3 o'clock in the afternoon. It was my mother. And I was talking to her briefly, and suddenly I could tell what I wanted to talk about, but the words weren't coming out properly. And I seemed to be forcing my conversation, and she couldn't figure out what I was saying. And quickly from there, I sat up on the edge of the couch. I broke out in an absolute soaking sweat. My vision went completely nuts, like a kaleidoscope, as it's been described to me, which is completely right, especially on my right side. So, you know, I'm thinking, what's going on here? You know, you just don't really realize what's happening. Suddenly, it came upon me that I was blacking out, and my vision went completely. The room just completely went white, and I saw like a gray on the right hand side, and I started to fall backwards. And I honestly thought at that time that was it for me. I even said to myself, boy, is this it? Like, it's a terrifying experience, because, you know, I mean, we're all going to end up there someday, but to happen that quickly to me was a little shocking. But so I ended up falling backwards on the couch, and the room just went completely white. The only thing I can remember from that is that to be honest with you, there was an incredible peace that was happening. I just felt like every load was lifted off me. And I don't know how long I was out for. This was a little after 3, but I must have come to. Now, the theory is that I went back and I banged my head, and somehow it moved, the blockage that I had. So I woke up gasping for air, which is as if you stuck your head underwater and you were let go. Managed to collect myself a little bit, had my cell phone, managed eventually to call my wife, because I didn't know what to do. You just so mixed up. She came home within 10 minutes or so, and realized right away that there was something wrong with me. She said my eye was drooping. I wasn't talking properly. My arms were very weak, and she knew right away she had to call an ambulance. So she called the ambulance. They showed up. By this time, I was starting to kind of regain some things. I think my talking, I'm not even sure, but my vision was still really bad. So they looked at me for a little while. They got me up and they walked me out. And my front steps is about 5 steps down to the driveway. And when I got to the top of the steps, they were holding me, and they asked me if I could go down the steps. I could not. There was about 35 steps there. I didn't know which was the real step and which was not. So I said, I can't tell. So we got down there in the ambulance, waited a while. they ended up deciding to take me to the hospital in Dunnville, Memorial Hospital, which is about a 40-minute drive from my house. And upon arrival there, I was seen immediately by Dr. Remington, Jeff Remington, who immediately realized that I was in trouble. And had he not taken that moment and that care to, realize right away that I was in trouble, I may not even be here today, or I could have been severely disabled if something hadn't moved. So right away, he switched things around. He told me I was going to the general in Hamilton and that Dr. Sharma would be waiting for me. These are things that I remember, don't remember everything, but they put me in an ambulance with a nurse down to the general, which is in about a 50-minute drive from Dunnville. And all I remember is having seen Dr. Sharma standing on the sidewalk waiting for me. Told me he was going to take care of me, and got me a little more relaxed and took me in. It was him and Dr. Wyman was there. And quickly they were doing things. Now they came to me and told me that I was going to be put in the CAT scanner, and they were going to see what was up. And they really didn't have any idea what was going on at that point, obviously. So, but they told me there was either an option of having a drug or having a catheter to take out the blockage, wherever it was. So they did that, came back, and they told me they were going to try the TPA drug. So they hooked me up, and the nurses were fabulous, just unbelievable, caring, So I started taking the drug, and at that point, my vision, I was staring up at a ceiling. I remember, the hung ceilings, and I could see the white bars on it, and there was like tons of bars. So my vision was not clear. My speech was not clear. I ended up in seventh floor ward, one of the sides there, and they kind of monitored me there. So I remember sleeping, and I remember waking up and looking up and seeing that ceiling again. But this time, my left eye had 1 bar, and my right eye, I could see 2 or 3 bars, which was really a dramatic change from earlier, the way it was. So, I thought, boy, I think something's working. And I'm thinking, well, I hope it keeps going, because this is kind of weird. I don't know how I'm going to function like this, but you think all these things when you're laying there. That evening, I was taken over to the other part of the 7th floor. And by the time nighttime came around, my vision was completely clear. My arms were functioning properly. I was talking. They were asking me questions, and apparently I was talking properly. So, I was there, doing tests and things. And this is the real kicker is you never want to go to the hospital on a Friday night of a long weekend, because, that you're going to be there for a while till maybe Tuesday, because nobody's in on the long weekend. So, which was fine, because, I basically refused to leave until they did every test they had to do. So I wasn't going anywhere, because I didn't want to have to try and come back, and I didn't want to, screw it all up. So they kept coming to me and asking me, and they were saying, like, I was sitting up on the bed, and the doctors were coming and saying, you don't have any effects from this. You don't have any like deficits or anything. And they asked me so many times, I started thinking, should I have something? Like I said, what am I not, putting this out there? But remarkably, it changed everything, like within a day of getting that drug. Now, my stroke, from Dr. Cantonese is my neurologist, just a wonderful person. I can't even explain to you. Everybody's been great. Dr. Sharma, Dr. Remington, and Dr. Wyman have basically saved me. I mean, I don't know, well, I do know, because I've been told that had I not, about 90% of the people that have a blockage in the back of their head don't survive. And a lot of times, if I had not fallen backwards, I may not even be here. I get that. That's the only stroke of luck that I had with that. Somehow it moved and the blood started flowing again, or I'd be severely disabled, or I wouldn't be here. So I have to thank them. And I don't think I'll ever have enough gratitude to, you know, when you have something like this happening, you think you're dying and then you're not. It's pretty traumatic. And the care I got was just remarkable. But Dr. Cantonese has been my neurologist since then and has told me a number of things that I had a lot of questions when this was over. And so I was in the hospital till I think Tuesday or Wednesday to get some heart tests done and things like that. And then it was kind of weird because, I mean, that is not a nice place, not a nice floor. And I really felt for a lot of the people on there that were certainly not as fortunate as I was because of their time frame of getting to the hospital. I remember walking because they wanted me to walk, and I was walking around, and I remember a lady coming up and asking me who I was visiting. And I had to say, well, I'm not visiting here, I'm a patient here. And she was like, oh, she just, so it is remarkable what really happened with me. And the reason I'm bringing up the point of saying that sometimes things are not what they seem. And I think that's my message today, is because by the time the ambulance attendants came to my house, I'd already had the worst of what was happening. And I clearly, fortunately, came out of it to a point where I may not have presented to them. Well, I know I didn't, because I have the ambulance reports, and they basically said I did not meet the criteria of a stroke on the protocols. So I don't know how you go from that to you're in critical condition, as I was told by Dr. Sharma, and then have that blockage in the back of your head. You know, I mean, some of the symptoms were very clear. I'm not judging, and I'm not criticizing, and I'm not trying to armchair quarterback at all. But I think my lesson today in a teaching mode is that when you see somebody and they present to you something, some symptoms, or even the ability to communicate, you know, you may not know what's happened already, and they may not be able to say, you know, half an hour ago, this is what happened to me, and now I'm here. So I guess, you know, that's my main point. My main point is that I had some wasted time. And if you look at, you know, you hear about the FAST phrase and things like that. And one of the most important things on there is time. And, you know, I lost about an hour by going to the Dunnville Hospital instead of going straight to the general. And I don't know what the protocols are, because I'm just not privy to that. But somehow I either did not present to meet those protocols, or some of the things I did was missed. And I'm not judging that at all, because it could have been me. I don't know. But I just want to make it clear that, you know, it was an issue that could have changed my direction and could have changed my life for forever, obviously. I've been told I could have been severely disabled. That's not a good thing. So, you know, if you're seeing people, or you have people that come, or you're talking to people, you know, maybe a little bit more conversation about what has happened before this moment, because all my bad moments, they clearly happened before help arrived. And somehow I was able to communicate to them, and they just did not see, well, they couldn't see what had happened, you know, 10, 15 minutes prior to that. And if the person like myself is not able to express that, then something's missed. And until I got to the general and they actually did a CAT scan and found out that that whole thing was blocked. And in that hour, it could have moved, it could have, there's a lot of things could have happened. And, you know, it's just a training moment, an educational moment that, you know, I'm trying to present. And so basically that's my story, and I am very fortunate to survive. I had a lot of questions for Dr. Cantonese when I was better, and I was able to kind of talk about it and research about it. And I'm very grateful for her, because she has been the most patient and the most caring. And I can't even give many words for that, because there just sometimes aren't any. I think we're all very fortunate that people forget about, they hear about the medical system. Oh, it's bad, hallway medicine and all that. But when you need help, it was there for me. And I'm always going to be grateful for that. So the only thing I can bring up now is my after effects. The after effects for me have been very minimal. I'm walking, talking, thinking. Sometimes I have a little cognitive issues. I have to write things down more than I used to, and to remember. But generally, I'm doing pretty good. The only thing that I can say is that, from my perspective, is that there may be some psychological problems from this, because I was having issues with, I was struggling with, I guess, apathy, and you know, sometimes my patience level is very low. And you know, before I was, you know, I go to anger quickly, and that's really not me. So I'm trying to work on that. But I think from a patient perspective, I could have used, or I could use more help that way. And I have reached out, and I am getting some help through the Niagara region and that kind of thing. I don't know if there was anything in regards to the general or any of that program, whether there is some psychiatric psychology psychologist type of accessibility, but I didn't see it, and I didn't have it. So that's really from a after effect perspective is probably the only thing that I didn't see or get. And you know, I didn't expect it. I didn't understand. I've learned more about it now, you know, stroke depression and things like that, how easy that can jump in and catch you. But I am getting some help with that. And I don't know, I really, some days I wonder why this happened the way it did for me, but why it doesn't happen the other way for other people. But again, I'm not going to belabor the thank yous, but I'm a very fortunate person, and I'm very grateful for still being here. And if I had pictures, I would show you right now, but I've made this point to Dr. Cantonese, is that for every patient that you find or you come across or you have to deal with, I want you to remember that they have family. We have two sons and a daughter, 4 grandkids, and you know, they're all grateful I'm still here, I think. You know, they've mentioned that, but you know, it's a ripple effect of that person outcome directly affects a lot of other people. So that's the last point I want to make. And like I say, I'm very happy to be here. I'm very fortunate to be here, and I'm really glad I was able to speak with you all today. And I'm here for questions, whether it's now or down the road. I know you can pass your questions on to Barb or Rhonda or Elaine, and I would be more than happy to. They have my information, so I'd be more than happy if something comes up after today that you can reach out and leave some information so I can get back to you with them, and I'd be more than happy to come back and get a hold of you in person. So thank you for having me. I'm not going to take up much more of your time because you had a busy day, but I do appreciate your time and your listening to my story. Thank you.
Thank you so much, Dave. Are there any questions for Dave? You can either unmute your line or you can ask them in the chat line, which you'll see at the bottom of the screen. I have realized with Zoom that we have to do the longer than anticipated pause. Well, it takes time for people to unmute or to type their questions.
I just wanted to thank Dave for that talk. I just wrote in the chat to you that I think you're a great speaker, and I really appreciated hearing your perspective, particularly about the the subtle after effects. Whereas you look 100%, there are those not so visible impacts that we forget about sometimes. So thank you for that.
Okay, Steph, I'm going to try and ask a question, but I'm going to mute my line.
Dave, this is...
Sorry, Steph's just going to come up. He's in the room and there's a lot of feedback.
Hopefully you can hear me now, Dave. This is Steph. I've had the chance to talk with you not too long ago, so good to see you, and thanks so much.
Yeah, nice to meet. Nice to see you. I can't see you.
My question is, Dave, it sounds like your stroke was complex. I'm wondering how the communication from the medical team to you and your family was in terms of explaining such a complex stroke.
Yeah, that's a good question, and I think it's important when families there, they don't know what's going on. They know there's something happening. I mean, for me at the house, my wife was there. So, she said, well, they're going to take you to Dunnville. And, I didn't know. And so she was kind of at a loss. She'd never been to Dunnville Hospital. So she went and picked my daughter up and finally got to the Dunnville Hospital just in time to see me being put back in an ambulance to go to the general. So I know Dr. Remington spent some time with her and explained that, this is what was going on and that I was heading to the general for some better care, where there was, it was a critical care situation. So when she got to the general, I was already there. And I have to say that the communication from Dr. Remington was very clear, and basically told me that he had arranged to have Dr. Sharma waiting for me at the hospital at the general, not to worry, he was great. So, away we went. Dr. Sharman was at the sidewalk. I remember that. And I remember him saying to me, I'm Dr. Sharman, I'm going to take care of you. And I you can't buy that. That makes you feel like you're in some good hands. So I remember going in, and nurses were extremely communicative, and they communicated everything was going on. They're very pleasant, keeping it light. And Dr. Sharma was great because he came to me and told me that, this is what's going on. We need a CAT scan, but you're not in good shape here. You're in critical condition, and we need to get doing something, just so you know. He gave me the options that they were going to do, and depending on what the results were. And once I had a quick funny story. I don't know how they usually do this, but I remember the nurse coming to me and saying after the CAT scan, "Boy, you must be a VIP." And I said, she was laughing, and I said, "Well, I don't know." She said, "I've never seen 3 doctors standing looking at the CAT scan when the CAT scan is actually happening." So the urgency obviously was, they didn't wait for a result or anything like that. The urgency was there, and they jumped on that. And a lot of that, I think was reflective on my outcome. And, I don't know what you can say about that, but, the professionalism and the communication and everything. And unfortunately, I never did see Dr. Wyman and Dr. Sharma after that. I've been trying, because of COVID, I was going to go to the hospital and make an appointment, go down to see them. But once I got myself pulled together, it was January, we were into COVID, and, that wasn't going to happen. So I'm hoping someday to do even if it's a Zoom meeting with the two of them, because I want to thank them personally, because it's very important to me to do that. But the communication Stefan was just, it was great. And up on the ward, excellent treatment, excellent. Every minute of the day, the nurses were just unbelievable. Coming, talking to me, spending time with me. They got a lot of stuff going on that ward, and I realized that. And, here I am sitting on the edge of the bed, and, there's a lot of other things happening, but they were more than pleasant, more than happy to come in and just communicate what was going on about my tests and things like that. So I have absolutely zero complaints about my time at the general, to be honest with you.
Thanks so much, Dave. We did have a question on the chat, just wondering, where was your stroke? Can you hear me? Sorry.
Yep. No, I can hear. It's my computer. The way it was described to me, and I can. So, Dr. King, mine was a basilar artery on the back of the brain. Now, she wrote here, the clot was at the very top portion of the blood vessels, basilar artery, on the back of the brain. The midbrain, top of the basilar portion, is the area that allows you to stay awake. And if affected, patients fall asleep, and sometimes they may not be able to breathe on their own and therefore gasp for air. Exactly where it was. And, you know, further than that, she said the white color is blindness. The top of the basilar artery gives two blood vessels called posterior and cerebral arteries that are responsible for carrying blood to the visual areas of the brain. And she got me a diagram and marked it above. So it was where the artery splits, looks like to me, from the pictures that I've seen. And it just went to the left and it stopped right there. It's quite large, actually. That, to me, they've told me that where mine wasn't like a frontal thing. Mine was in an area where that's where life is. That's where all your motor functions, all your heart rate, your temperature, and I realized after that, you know, when I'm not kidding, I have never broken out in the sweat that I did that day. And I literally, my t-shirt was just soaked wet, like somebody dumped a bucket of water on me. And I think that being there, regulating my temperature, that's what maybe caused that. I'm not sure exactly, but all of the things that she's told me, or all the things that happened to me, all fall into that category. I didn't have like something up here where my, you know, the right side, left side thing going on where people have problems that way. Mine was in, well, they told me it was probably in one of the worst spots it could be in. So does that answer the question?
Yes, thanks, Dave. Are there any other questions? Thank you so much, Dave, for taking time and sharing your experience with us. And I loved some of the quotes that you had talked about. And I think it's really letting us know that some things may not always be as they seem. And so I think you're right, is really, I think you highlighted the key points of when you're seeing those fluctuating symptoms and really describing and getting that history about what you see and you know, really how that could have changed. So thank you so much, Dave, for taking the time and sharing your story. We really appreciate you doing that. And we also really appreciate you giving back with your roles with March of Dimes as a peer volunteer and as part of our family, our Regional Stroke Patient and Family Advisory Council. So thank you so much.
Well, thank you for letting me come. And I say being part of the Stroke Network is very important to me. So I'm really glad I'm starting to get into these things. Stefan's got me down a path there that's good. And just going to go as things go along here and try to have input and try to belong to it. And whatever I can do, more than happy to be involved. So feel free to reach out to me anytime. And if anybody has any other questions, they can always get a hold of me and we'll go from there.
Thank you so much.
Thank you.
So while Barb is doing the technical aspects behind the scene, it is my pleasure to introduce our next speaker, Dr. Christine Hawks, who's going to talk to us about stroke endovascular therapy. Christine is, Dr. Hawks is currently a first-year interventional neuroradiology clinical fellow at McMaster University, trained to perform interventions such as mechanical thrombectomy for stroke. Dr. Hawks completed her training in adult neurology at McMaster University in 2018. And then she went on to do a clinical fellowship in vascular neurology at the University of Pittsburgh Medical Center, which has one of the largest volumes of stroke centers in the US. So we are thankful to have Christine back with us doing her interventional training And I welcome Christine to do her presentation.
Thank you so much, Rhonda, and thank you to everyone who coordinated today's event and for the invitation back again this year. I am also very appreciative of you, Dave, for sharing your story and talking about how it has impacted your life, as well as how the various members of the stroke team were able to facilitate your care. I'm going to dive in deeper into what we actually do on the endovascular side. So when a patient like Dave or someone else has an occlusion that needs to be removed mechanically, that's when they would come to the Angiosuite, where we do procedure called mechanical thrombectomy or endovascular treatment. So that's what I'm going to be sharing with you today. It may be a little bit technical, but hopefully we can walk through it step by step and it'll be clear. And if there's any questions, don't hesitate to unmute and ask your questions, or if there's anything that pops up in the chat box, I can address that at the end. What my main objectives for this talk are to really explain why we use EVT or endovascular therapy for acute ischemic stroke, which patients we select to go to the Angiosuite and why, and what are the techniques or the challenges in actually trying to remove a clot from the cerebrovascular circulation. So I wanted to start off by asking a question to the audience to see how many of you have actually seen someone go for endovascular treatment. Sometimes when we're transferring patients from outside hospitals like Dunnville or elsewhere, the EMS crew comes and helps us transfer the patient onto the table. And sometimes I see them stick around and watch the beginning of the procedure, or kind of get a lowdown from someone like Dr. Ishkowski, who's very keen to share what's going on. But I'm curious, has anyone in the audience here seen one of the procedures? You can just either raise your hand in the participant box or type it in the chat box.
I don't think you can see the hand raising, but you could give a thumbs up in the reactions.
So lots of answers: no, never. If you haven't had the opportunity, if it ever comes up and you're transferring a patient or you've brought a patient and we're about to start the procedure, if you have the opportunity, please don't hesitate to ask if you can stick around and see a little bit of the procedure, because I think it's really helpful to understand what we do if you can actually see what happens in the Angiosuite. And just to give you an example, when I was training my stroke fellowships, the paramedics in Pittsburgh would send messages to the stroke team in these alerts that we would get through our email and on the stroke pager, and they would describe what they're seeing with the patient. Like in Dave's situation, the paramedics could have described what he was saying and give some basic information. So it was an interesting system where the stroke team could be alerted ahead of time and kind of have a sense of what the paramedics are seeing at the scene. Some of them were very descriptive. Googly eyes was one of my favorites. So let's start off with a case. This is a 75-year-old man with multiple vascular risk factors that you can see there. He spoke with his family before going to bed and then woke up at around 1 a.m. and fell out of bed. And his family called EMS, and when they arrived, they noticed that he was not moving his right side at all and he was not speaking. So in this case, very clearly had stroke symptoms, and this was identified very quickly. He was brought immediately to Hamilton General Hospital, where he arrived about 40 minutes later, and the stroke team was there to meet him and did the NIH stroke scale, which is a scoring system for the clinical examination in acute stroke. Higher the NIH, the more severe the problem is, the more severe the deficits are. So his was in the severe category. You can see the breakdown of where he had problems along the score. So he immediately went for a CT head that didn't show any hemorrhage. That's the main thing that we exclude on the CT head before giving a clot busting medicine like TBA. And we calculate an aspect score, which is a radiographic way of calculating any early subtle stroke changes on the CT. But what we're hoping to see when we do a CT head in a situation like this is no hemorrhage and very minimal early changes, so suggesting that there hasn't been a large stroke already. And so he was able to receive IV TPA because he was found to be a candidate. And unfortunately, we don't have time to talk about that in this presentation today, but that's another important piece of the stroke process. Here's a picture of his imaging, and you can see the arrow pointing out here where the middle cerebral artery is, one of the main arteries supplying the left side of the brain. And for those that don't read CT scans very often, the left side is over here and the right side is over here. So it's a little bit flipped from what you would expect. It's like the patient's legs are sticking out straight at you. So on the left side, there's a hyperdense or a very bright spot here that's suggestive of a clot. And then when the patient underwent the CT angiogram, which is the blood vessel test, to allow us to look at the blood vessels in the brain, you can see that this blood vessel clearly doesn't continue in its normal pathway, and there's a blockage right there that corresponds with where this hyperdense vessel is. So this is the kind of patient that we would take immediately to the Angiosuite and perform a diagnostic cerebral angiogram first, so injecting contrast dye into the blood vessel directly. And you can see that here in this panel. This is a tiny catheter up in the left internal carotid artery. And you can see that this middle cerebral artery is not filling this normal area that it should be filling because there's a blockage here. This second panel just shows you that the brain is trying as much as possible to get blood flow to this area of the brain by using what are called collaterals, or these other little blood vessels that are actually blood flowing from different arteries, not the middle cerebral artery, to try to backfill that area that's not filling because of the clot. So this patient underwent mechanical thrombectomy, and fortunately, using a device like this, there was full recanalization, meaning that the blood vessel was completely opened and there was no small clots elsewhere. And after the procedure, you can see that his stroke scale went down significantly to 3, which is a minor, in a minor stroke kind of category. And this is the follow-up CT scan that he had the following day. That's our standard protocol. And you can see this darker shaded area is where the established stroke is. So if he had not had the procedure, the stroke would likely have involved about 2/3 of the left side of the brain, but because the blood vessel was opened up, there was only a small area of damage here. You can see this dark spot. And he was able to be discharged home a few days later. And he was happy. So the big concept here is that these are the arteries that carry blood to our brain, the left carotid, the right carotid. And if a clot comes from somewhere, either from the heart or from a blockage somewhere in one of the arteries, and blocks off one of these main arteries, immediately the tissue that would normally have been supplied by that artery starts to become ischemic. It's not receiving enough blood flow and oxygen, so it starts the process of dying. We do, however, have time, because of those collaterals that I showed you, that the tissue doesn't die all at once. It takes some time. And the goal, when there's an area that's at risk of dying, this part that's still alive, that's not receiving enough blood supply but isn't quite dead yet, and this area that might already be permanently dead, the goal is to select patients for endovascular treatment who have a large mismatch between the tissue that's still alive but not getting enough blood flow and the tissue that's completely dead. So we call that the core, the part of the brain that's permanently damaged, the stroke that's established, and the area that's at risk of damage if the blood vessel was not opened. That's called the penumbra. And the goal is to restore blood flow as fast as possible to minimize the size of the area that's permanently damaged, or to minimize the core. And why do we have to move fast? Why do we try to do these things as quickly as possible? Well, we know that the average person with this type of blockage loses 1.9 million neurons per minute. So as minute by minute, more and more damage is accumulating. So we have to go fast. But we also know that this is an average estimate. So everyone is different. Everyone has a different anatomy and different collaterals and different baseline. And there's probably a lot of other factors that we don't fully understand that go into this. But there's a range. So there are people that have really favorable anatomy and really good collaterals, that their tissue can survive a lot longer than some other people who, with the same blockage, progress their core, their infarct, it grows at a faster rate. So we call these lucky people that have good collaterals and good anatomy slow progressors, because their core infarct is growing slowly. And these other people that unfortunately have unfavorable anatomy and not good collaterals, those are fast progressors. But when we're seeing a patient, and you're seeing a patient in the field and you're picking them up, you have no way of knowing whether they're a fast progressor or a slow progressor. So the bottom line is we have to move fast no matter what. And we have evidence for this from multiple randomized controlled trials. These are the big 5 trials that came out in 2015 that looked at the endovascular therapy in the early time window, meaning from 0 hours to 6 hours, and randomized patients to receive endovascular treatment or to receive standard of care. And so that would include TPA for people that were eligible. And they had different cutoffs and different criteria for each of them, but they were all overwhelmingly positive in favor of endovascular treatment. And then what Dr. Szkowski will talk about more are the late window trials. So the randomized controlled trials looking at patients that are in the 6 to 24 hour window. Those are DAWN and DEFUSE3, and they used other different ways to measure core and penumbra to show that patients in this late window actually still have a mismatch between the area of tissue that's completely dead, irreversibly damaged, and the area that could still be salvageable if we were able to open the blood vessel. And they were also both overwhelmingly positive as well. So we have very good evidence that this treatment works. When the data is compiled in a meta-analysis, so the HERMES Meta-Analysis looked at those 5 initial trials from 2015, the early window trials, and compiled all the data from each individual patient and looked at one of the common outcomes that we look at in stroke research, which is called the modified Rankin score, a scoring system of a patient's level of disability from 0, meaning no symptoms, no disability, to 6, meaning death. And they showed that in the patients that didn't receive endovascular treatment, or the control population for all of these trials, that they had more unfavorable outcomes compared to those who received endovascular treatment and had the intervention. And you can see that here in this grotto bar. So the patients that received endovascular treatment and achieved a modified Rankin of 0 to 2, which is patients that can go home and perform their functions that they were doing before, maybe with some restrictions or some disability, was 46% versus only 27% in the control. And remember, some of these patients received IV TPA, so that probably helped with some of these patients in the control group. And so Dr. Szkowski, I think, will show you how this differs in the late window trials. And we use a measure called number needed to treat, which basically means the number of patients that you need to treat to have one good outcome from a treatment. And for endovascular therapy, that's 2.6, which is extremely low in medicine. So I wanted to ask the audience if anyone knows anything else in medicine, any other treatment that we do that has this low of a number needed to treat or this powerful of an effect? You can try to answer in the chat box if you have an idea. Lots of people are saying E. Some answers of B, C. Kind of all over the place, but a lot more people saying E. Well, surprisingly, there's only one thing on this list that has a similar number needed to treat, and that's antibiotics and sepsis. And that has a number needed to treat of 3, similar to endovascular treatment. Things that we do without question, like starting aspirin for TIA or stroke, actually has a slightly high number needed to treat. So 38 patients have to receive that treatment for 1 person to benefit. Nitro for chest pain, pretty good. Number needed to treat of 5. Lifestyle modification for diabetes, pretty good, but still higher than EBT. So I just make this point that we never question treating patients with antibiotics and sepsis, but we should be thinking about EBT the same way. It's such a powerful treatment, and we have the opportunity to intervene with something like this. So we should be doing everything possible to include patients and have them be brought for this treatment if they're eligible.
Dr. Hawks, just before, oh, we're probably going on, there was one question before you move on to sort of criteria for EBT.
Mm-hmm.
Is there any guidelines for NIH scoring or ranking for patients getting TPA? I know they're not really covering it in this talk, but, and then what would an aspect score for somebody getting TPA? I know you're likely going to get into that for EBT.
Yeah, I will talk about that for EBT in a couple seconds. For TPA, there's no minimum NIH to give TPA. We do consider giving it when the patient has deficits that are disabling to them. So for someone with a visual field cut, similar to I think what Dave was describing, that would only get you 2 points on the NIH, but would be something that would be considered severely disabling, because if you have a permanent visual field cut, you're not going to be likely to go on to back to driving, and your work may be affected. So there's no minimum NIH for TPA. And then there's a relative contraindication for a high NIH for TPA, but there's no minimum. And then the other question around aspects, when they did the NINS trial, which was the big IV-TPA randomized control trial, they didn't calculate aspect score and use that as a determinant as to whether or not patients could receive IV-TPA. That being said, we know that patients who have a lower aspect, meaning a larger area of permanent damage on the CT scan, they do worse, and there's a higher risk of them having a worse outcome or having a bleed, but there's no specific cutoff per se. But you also have to take into account that if the area that's where the blockage is completely damaged and it's showing up as a low aspect score, then that there's not going to be anything that reverses that permanent damage, including opening the vessel with EBT or even with TPA. So those are the things that come into consideration.
Thank you.
So let's talk about guideline eligible patients for the early window for endovascular treatment. So they must have what's called a large vessel occlusion, which is one of those major blockages. That means either the first segment, the large part of the MCA, the internal carotid artery, and some will consider the very start of the second segment of the MCA, as well as the basilar artery, like what Dave described as when he had his stroke. Per guidelines, patients need to be adult patients for this treatment. Children were not included in those randomized control trials. There have been case series of children, predominantly teenage children with, or teenagers with, that have been treated successfully. So it's not an absolute contraindication, but it does pose other challenges. And we do consider EVT primarily when patients have disabling stroke symptoms, an arbitrary NIH cutoff of 6, but that's sort of per the guidelines, but there are situations where we would consider treating someone even if they didn't meet that NIH of 6 cutoff because their symptoms were disabling. And they need to have brain tissue that's still salvageable. So if the entire territory is already completely infarcted and permanently damaged, then opening that blood vessel is not going to reverse that, and so it would be futile to do a procedure to open that blood vessel. And the patients need to have a reasonable baseline function. So in the trials, that was a modified Rankin of 0 to 2 at baseline. So patients living at home that could be living independently. Have we treated people that have an MRS of 3? Yes, in certain situations, we would consider it. So those are the guidelines. But my interpretation of this is really that for every single patient that we see, since we're moving so quickly and the information is coming at us so fast, we really need to treat everyone as if they have a treatable stroke until it's proven otherwise. And we do know that faster is better. So the faster that the patient is brought to endovascular treatment and the faster that the blood vessel is opened, the better patients do. So this is a graph showing that with time here increasing, the likelihood of a good outcome starts to decrease, and that crosses the confidence interval when you get to around 7.3 hours. This was looking at the data from those 5 big trials that I showed you for the early window. So what's the process like? What do we actually have to do? What are the steps along the way? Well, EMS plays a huge role in bringing patients with severe stroke symptoms to the emergency department. Rarely patients will arrive on their own, but these patients who are severely affected by stroke symptoms are typically arriving by EMS. And then they have to arrive in the emergency department, and usually a pre-alert goes out to the stroke team who meets them in the ambulance bay as they're arriving, and they're brought from the emergency department to the CT scanner, and they have usually a CT and a CT angiogram, and then they're determined to be an endovascular candidate by the stroke team who speak with the patient's family and also figure out if the person is eligible for TPA, and then they're brought for endovascular therapy. And so what do we actually do on the EVT side? Well, we have parameters that are monitored for us as well. Along each of these stages, there are certain parameters that we try to meet as far as times go, and our goal from door to recanalization is less than 90 minutes. Recanalization is the time when the clot is removed and the blood vessel is now open. So once someone gets to the Angiosuite, we have a full team that works together for this procedure. We have 2 nurses, sometimes 3 nurses, 1 medical radiation technologist, so their job is to help us use the machine to do the procedure, 1 neurointerventionalist, sometimes there's a second person, and sometimes there's a fellow as well, like myself, that's helping. This is a picture of one of the types of machines that we use for this procedure. It's a biplane suite, which is not something that's available everywhere. In our region, Hamilton General is the only place that has one of these biplane suites. And the reason that we need x-rays coming from the front and coming from the side to do this procedure is because we're trying to navigate into tiny blood vessels in the brain. And if we just looked from one angle, we could see something like this that looks pretty scary. But if you look from the second angle, you can see that it's actually just a mom taking care of her baby. So it's similar in the Angiosuite that if we only had one view, it would make it much more challenging to perform the procedure safely. The second step after the patient has come into the room is actually figuring out how we're going to get into the blood vessels. So typically for stroke cases, we're using the femoral artery at the top of the leg. And sometimes we're using ultrasound, as you can see in this picture. And we're puncturing and then feeding tiny wires and tiny catheters up from the leg all the way up to the brain and to where the clot is. Sometimes we encounter challenges with anatomy from the aortic arch. So you can see this is on the left, straightforward anatomy, and you can see on the right that this is more challenging anatomy. And we tend to see this more with older patients that have had risk factors for a long period of time, and their aorta and all of their cervical arteries have become affected by atherosclerosis over time. And then we perform an angiogram where we inject contrast dye into the artery of interest, and we're looking for a blockage like this. So you can see the contrast flows up through the internal carotid artery. It's filling this artery, which is the anterior cerebral artery, but it's not filling the middle cerebral artery. And this person also has excellent collaterals coming from that anterior cerebral artery down to try to fill that territory where the blockage has occurred. And then the fourth step is to actually perform the thrombectomy, so the procedure to try to remove the clot. That I'll try to show you here with a video.
We can go in from the femoral artery in the leg with a catheter, as you can see here, place it in the carotid artery in the neck, that's the blue catheter. Through that catheter, we take up a smaller catheter, a microcatheter, and we catheterize the arteries inside the brain, the carotid artery, and into the middle cerebral artery. You can see the clot within the middle cerebral artery, which supplies blood to that half of the brain. So we bring up our microcatheter all the way up into the middle cerebral artery in the brain and cross the blockage. Once we're across the blockage, we bring up a mechanical thrombectomy device, which is kind of a stent on a stick kind of configuration. It's a stent-like device that we unsheath within the clot in the blockage. You can see the stent is opening up and actually restoring blood flow immediately. We then give it about 5 minutes, allowing the radial force of the stent to open up outward and allowing the clot to extrude within the lumen or inside of the stent. After the 5 minutes is over, we inflate a balloon in the carotid artery in the neck, which arrests flow, and then we pull back the stent retriever device with the clot entangled inside it into that balloon catheter. The purpose of inflating the balloon in the carotid artery in the neck is to reverse flow from the brain arteries and into the catheter out of the patient's body. In this way, any particles that break off from the blood clot within the stent retriever will get sucked out of the patient's body. They don't go out distally and cause more strokes.
So that's one technique, and there are lots of other ways to do this. Other techniques, sometimes not using that balloon down below and using other catheters, kind of like a vacuum cleaner rather than a stent. But there's lots of different ways to do this, and sometimes we combine them as well. So part of our job as the interventionalist is to try to figure out for each particular patient's anatomy and the type of clot that we're dealing with, what technique might work the best. And there are studies that are looking into that. And sometimes we try everything and we open every catheter we have and we still cannot open the blood vessel. So I tell families when I'm talking to them about the procedure ahead of time that about 80% of the time in straightforward cases, we can open the blood vessel. But that means there's 20% of the time that we do everything possible, everything we can think of, and we just can't get the clot out. There are other things that may make the procedure more challenging. Like you can see on this left panel that this is an internal carotid artery injection, and this is in the neck on the left side, and there's this severe narrowing at the carotid bifurcation, or just at the proximal internal carotid artery. That's because of atherosclerotic plaque. That was probably the cause of the stroke, but we have to try to figure out what to do with this. how to get through this tight stenosis, and then what to do with it afterwards if we're able to remove the clot. And then even more challenging is sometimes there can be plaque inside the intracranial circulation. So you can see here on the right, there's this narrowing of the middle cerebral artery because of atherosclerotic plaque inside the brain. And that's even more challenging for us to deal with. And sometimes we have patients that receive IV TPA at one of our outside centers, and the clot was here where you can see this red dot. That's at the end of the internal carotid artery. And then when the patient got to us, the clot had broken up and had blocked off 3 arteries instead of 1. So that can be a challenge for us as well. So let's talk about another case. This is a 64-year-old man with a history of smoking and sleep apnea. He was seen at around 5 a.m. when he got up for his morning, and he went to have a cigarette and collapsed. So his wife found him shortly afterwards with left-sided weakness, very clear stroke symptoms with a right MCA syndrome. And he lived in the Niagara region, so he went to his local stroke center. He had a CT scan done there, and we're paying attention to the right middle cerebral artery territory over here, and we're looking for any signs of smudging that would mean a low aspect score, and we don't really see much of that, so that's good. And he had a CTA there that showed this blockage on the right side in the middle cerebral artery. You can see where there's no longer normal blood flow to that side of the brain compared to the left middle cerebral artery. So he received IV TPA through telemedicine and then was transferred to Hamilton General Hospital, driven with paramedics from St. Catharines to Hamilton. And the process becomes a little bit more challenging because there's more steps now. So not only is EMS involved to bring the patient to the local primary stroke center, the patient arrives in the emergency department, has a CT scan, but now they have to be transferred out and to Hamilton, where sometimes we will repeat a CT scan before the patient goes for endovascular treatment. So the parameter that we're interested in here is the time it takes from when the patient arrives in the primary stroke center to when they leave, and that's called the door in, door out time. So we're trying to look at ways to minimize that as much as possible. So this patient arrived to Hamilton General Hospital, was supposed to get a routine follow-up CT because it had taken more than 1 hour, and he was severely agitated because some of our right MCA syndrome patients, because they don't realize that they have deficits, they think that they're normal and they try to get up off the stretcher and try to walk out, but they can't. So he had an NIH of 13. We know that the NIH stroke scale is more heavily weighted towards language, which is a left hemisphere, for a dominant hemisphere problem. So patients with a right MCA syndrome tend to have a lower NIH stroke scale, but still severely disabling. So he came for EVT, and now we're looking at what the time is from that second picture, that CT scan on arrival, to our puncture time. And so he had this angiogram that here's dye injected in the right internal carotid artery. And you can see that this right MCA, there's an abrupt cutoff. Again, he's got some collaterals coming from this open right ACA to try to backfill this MCA territory. And his procedure was successful. Immediately after the procedure, he had some improvement, and we see this sometimes, but then the following day, he was dramatically improved. So it's great when we see improvement right away on the table, but it doesn't always happen immediately, and patients can continue to improve over the next several days, and he was able to be discharged home. So here are the main conclusions from my talk. Stroke treatment in general, whether you're talking about EVT, TPA, or any type of stroke, is really a team sport, and there's so many different players, and we all need to work together to move fast. And time still matters, but every single patient has a slightly different time window. Their tissue is on its own time scale based on anatomy, collaterals, and probably other intrinsic factors as well. So regardless of the patient in front of you, you need to move fast because you don't know whether this person's progressing their stroke at 1.9 million neurons per minute, or if they're one of those ultra fast progressors that's losing 27 million neurons per minute with the same type of stroke. And we should try to optimize every single step along the way. There's so many steps and there's so many pieces, but working together, we can try to optimize each one of those and cut down time. So if you are interested in learning more about EBT specifically, I was really privileged to work with a few internal medicine residents who do this amazing internal medicine podcast over, since COVID happened. I was able to do an interview with them, and it was on endovascular treatment. So this is the QR code if you're interested in hearing that and learning more. They also are an amazing resource for lots of other medical topics.
Are there any? Thanks, Christine. Thanks, Dr. Hawks. That was an amazing presentation and a great overview of endovascular therapy and the inclusion-exclusion. I loved your analogies about really understanding that pathophysiology and what happens in the brain. Are there any questions for Dr. Hawks? So one of the questions in the chat is, do they always need to access from the femoral artery?
That's a really great question. For our diagnostic angiograms and for some other procedures, we've been moving towards using a lot more radial access, similar to cardiology, because of its safety and for patient comfort. In the vast majority of acute stroke cases, we need to use really large diameter catheters, and they don't fit through the typical radial artery setup that we have. So we usually use femoral access for stroke cases just to be able to put our large catheters through the artery safely. But we have sometimes used radial access or brachial access or even direct carotid puncture for stroke cases, depending on the anatomy. So sometimes you can imagine if there's blockages somewhere, like the patient has bilateral femoral occlusions, or they have an aortic occlusion as well. We've had that. The only way to get to the clot is through the arm, so we've had to do that. Or if the arch is super tortuous, sometimes the only way to get to where we need to go is through a direct carotid puncture. But those are rare cases for stroke. And so the workhorse for us is the femoral puncture.
Any other questions for Dr. Hawks?
Dr. Hutz, this is Steph. Thanks so much for a great talk. Question for you. I just wonder if you feel like there's any value in the utilization of automated software like rapid software in the 0 to 6 hour window like we're seeing in the expanded window?
That's a great question. Where I did my stroke training for was where the DAWN trial was started with Tudor Joven in Pittsburgh. And so we had access to rapid software, and we didn't use it in the early window, mainly because it doesn't tend to give you information that helps change your management. In the early window, we tend to have a lower threshold to treating patients, and we have a mixed population of both fast progressors and slow progressors, whereas in the late window trials and the late window timeframe, we're selecting for patients that already have good collaterals, because if they're surviving out to 12, 16 hours with an occlusion, they have to have good collaterals to get there. So these are slow progressors. And what the worry is with fast progressors, the patients that are growing their infarcts rapidly, is that another step like CT perfusion just adds time without much benefit. And the second thing is that the thresholds that we use for CT perfusion were established based on the late window. And there's a phenomenon called ghost core that can occur when we use CT perfusion in the early time window, where it looks like they have a large core infarct, but really when you open the vessel, they end up having an MRI or CT the next day, and they don't have that large core that the CT perfusion predicted. So I worry that if we start using CT perfusion in the early window, we might be excluding patients that could benefit, and we're costing time. Where I think there is promise in AI in the early window is automated software that detects those other things on the plain CT head. So like the hyperdense vessel that I showed, or the gaze preference, or aspects. I think that those automated software programs that use those parameters and can alert an emergency room physician that this patient may have a large vessel occlusion, you need to call the telestroke person, or you need to call your local stroke person. I think those can be very helpful in the early time window.
Dr. Hawks, you talked a lot about time and how quickly we need to get patients to the angio suite. Are there things that we can consider or do to really help get faster time? Or if I'm sending in the emergency department or at one of our referral sites, what are some things I need to do and consider when I'm sending that patient to make sure that that penumbra doesn't become core, dead brain?
There are a lot of things that we can do to try to speed things up. And a lot of it comes down to working in parallel. So while the emergency room physician is gathering some information, they're already having their business clerk call the telemedicine physician or getting them on the line, and they're already starting to get their nurses to get the TPA ready, and they're already looking to see if there's an EMS crew that might be available to bring this person to Hamilton if they're not already in Hamilton. So trying to start all of those processes early and trying to start them all at the same time, it requires a lot of multitasking and teamwork for everyone. And but I think working all of those things at the same time really can cut down on the time that it takes to get a patient to EVT. We're often right at the console with the stroke team when the patient is arriving in Hamilton. If one of the stroke fellows or physicians says, hey, we might have an EVT case, the interventional fellow often comes down to the console and looks at the imaging right away. And then while the stroke team is getting the TPA ready, we're starting to get the endovascular team to open the packages that we need and getting the patient on the table altogether. And we've had a good experience with EMS crews helping us transfer the patient into the room. And that can be helpful because if we have 2 extra people to transfer a patient from a stretcher to the table, that means that our 2 nurses that would normally be doing that job are now able to go get the medications that they need to give sedation, or they're able to start helping the technologists set up other parts of the procedure. So it really requires everyone working all together and trying to find these little areas that can speed up the procedure or the time to get to the procedure.
Are there any other sort of pre-procedure preparation that we need to think about if someone's going for endovascular therapy that would be different from, say, someone who's just getting TPA?
One of the most important things from a safety perspective is making sure that the patient is hemodynamically stable and has been set up from an emergency department standpoint to come for a procedure. So ideally 2 intravenous lines that are working, and we ideally like to have a Foley catheter in just to help facilitate the procedure, because sometimes it can take longer than expected. So those are some of the things that can start to happen on the emergency department side. Things become a little more complicated when the patient is truly unstable, and we have a pathway for that as well, where we also involve our anesthesiologists. So they like to have things set up slightly differently, and sometimes that requires changing our setup a little bit so that we can have an arterial line for them, or they can put one in quickly while we're preparing the patient and cleaning and getting our equipment opened.
Any other questions for Dr. Hawks? I have one more that had come to my brain, but I don't know if there's anyone else from the chat line or from the audience. Dave, Dr. Dave has a question.
I have more of a comment than a question. So I'm a layperson, and I have to say that your presentation was just very well done. easy to sort of understand from a person who may have had to have that procedure done, to know what's going on. And I think explaining it the way you did was just great. And for somebody who doesn't understand a lot of medical things, knowing more now about that gives me a little comfort, because, you know, you don't know about life, right? You don't know if, you know, you've had one, you don't know, right? And so thank you very much for doing that. And the other thing I want to say is thank you very much for doing what you do, because I just don't know how you do it, quite frankly, but I think we're all grateful for what you do, saving lives and helping people. And I know there's more people like you out there, but I'm going to just say it to you because you're here. So thank you for what you do.
Thank you, Dave. That means a lot.
Dr. Hawks, one question I had is, in this age of the pandemic with COVID, how has that changed sort of our approaches with sort of our hyperacute stroke processes?
It has definitely changed things. So when we're talking about seeing patients in the emergency department, we now talk about a protected code stroke. So ensuring that all of the members of our team are kept safe, because often when these patients are arriving with EMS, we don't have a lot of history about whether they've been exposed to anyone with COVID, or they have any symptoms of COVID, or what their status is. So we've tried to facilitate minimizing the number of physicians and healthcare practitioners that are interacting with a patient who has an unknown COVID status. And on the endovascular side, we've made some modifications to our Angiosuite to make it safer during the COVID pandemic. So this has meant moving certain equipment out of the room so that if we do happen to do a stroke case on someone who's COVID positive, that we don't have to throw out a bunch of equipment that has been contaminated potentially. And we do have a special HEPA filter that is in the room when we have a suspected COVID patient. We have had to do a few endovascular procedures on someone that either was unknown COVID status or may have had some symptoms. And so the entire team dons the appropriate PPE that's necessary. And we've tried to ensure that everyone on our team is kept safe when there's a potential COVID positive patient.
Thank you so much, Dr. Hawks. Any more questions? Okay, thanks. That was an amazing presentation, as I said, and a wonderful overview of our endovascular therapy. So thank you so much, Dr. Hawks.
Thank you.
So next on our agenda, Steph and Paliuso and myself are going to share a bit of you, and I'm just going to pull up my screen. And what we're going to do is talk a little bit about some of our metrics and our outcomes that we are seeing related to our endovascular therapy. So I realized that I actually didn't introduce myself. I figure most people know me, but I also have to recognize that everyone may not. I'm Rhonda Whiteman. I'm the clinical nurse specialist with the Regional Stroke Program. And I'm the endovascular lead for our region. And Stefan Paliuso is our regional stroke program director. And so Steph is really responsible for implementing stroke best practices across the continuum. So I'm going to start off and then Steph will continue on. What we're really going to talk very high level in the next 10 minutes is a bit about some of our volumes in Central South. And for those of you who may not know our region covers the H&HB LIN, or what used to be the H&HB LIN, and the Waterloo-Wellington LIN. We're going to talk about volumes, the proportion of patients that are treated and those that aren't, some of the reasons why patients aren't treated, what are we seeing in our patients, and what outcomes are we seeing. So just to give you a bit of a history, as Dr. Hawkes has said, we know that those 5 landmark trials were released in 2015. At the Hamilton General Hospital, we launched our endovascular program in August of 2015. We started sort of during daytime hours as we were getting our processes in place. So in 2015-16, we only did 17 cases. And about 82% of those were local cases who came through the emergency department at the Hamilton General, and 18% were from our regional partners. We expanded in June of 2016 to be 24/7. We increased our cases to 68 cases in that fiscal year, and about half of those coming through the Hamilton General, through the emergency department, and half of them coming from our regional partners. We then, in 2017-18, as we were implementing our endovascular program, we were fully implemented at all of our regional centers. We were doing 100 cases, with about 45% of those being from the emergency department and about 55 from our regional cases. We started implementing our 6 to 24-hour planning in December of 2019. And we increased you can see our volumes were still fairly stable in that fiscal year. We started in June 2019 implementing our 6 to 24-hour endovascular protocols in June. And then through the rest of the region, the rest of that fiscal year. And so Dr. Ostrowski will talk a bit more about that, but Dr. Hawkes talked a bit about that with some of the artificial intelligence, the automated software. Last fiscal year, we provided endovascular therapy to about 100 to 145 cases. And you'll see that we very much are about 40%, 35 to 40% come through our emergency department, but 60 to 65% are from our regional partners. So talking a lot about that processes that Dr. Hawkes talked about, you know, that door in, door out process, how can we look to achieve efficiencies? We, this fiscal year, are projected to provide endovascular therapy between 160 to 175 cases. So our volumes will certainly continue to grow. When we look at how we evaluate some of our metrics, there is a provincial report card, a dashboard that evaluates the proportion of patients who receive endovascular therapy by the province, by the organization, which you can see on the right-hand side of the screen, and then by the LHINs. So in Ontario, the proportion of patients who receive endovascular therapy over all of the patients who have an ischemic stroke is about 5.2%. When we look at Hamilton Health Sciences, our proportion of patients who receive it is about 4.1. The top performer in the province is London Health Sciences at 8.9%. So you can see we're providing a lower proportion of patients than the top performer. When we look at our 2 LHINs, the H&H-B, we're at about 4.8% of all patients. And in Waterloo, Wellington, we're about 3.6. So certainly one of our strategic priorities and one of our priorities from the hyperacute realm is to ensure that we have increased the proportion of patients who are receiving endovascular therapy. What you'll see on here is you'll see we have the one in the center is the Hamilton General, which is the Regional Stroke Center and our endovascular center. We have 5 thrombolysis providers in our region. So number 6 is DMGH. Number 19 is Brant Community Health System. Number 10 is Grand River Hospital. 11 is Guelph General Hospital, and number 5 is Joseph Brant Hospital. We have built systems to ensure patients across at those thrombolysis centers are doing that initial workup that Dr. Hawks had discussed. When we look at the proportion of patients who are transferred to the regional center who receive endovascular therapy, we are at 73%. That was the top performer in the province in fiscal year 19-20 Q1-2. And it really is based on a lot of the relationships and processes we've built. There is, as we go around, if we look at Guelph, they had transferred 19 cases and 58% of those patients were treated. We sometimes will describe that the road from Guelph is sometimes when patients get to us, what we find is the reason they're not treated is they're improved or the vessel has reopened. If we look at Grand River, 26 cases were transferred, 73% were treated. We look at Brant Community Health System, 24 cases were transferred, 88% of patients were treated. If we look at Joseph Brant, 23 cases were transferred, 78% of patients were treated. And in Greater Niagara General, 28 cases were transferred, 75% of cases were treated. So you see, we work very closely to have our processes for these cases across the region. When we look at the cases that were transferred and not treated, what we see is if you look at the blue, 26% of the time they weren't treated because the aspect had worse, the aspect had decayed. What that really means from what Dr. Hawks had talked about is that stroke had extended and that penumbra now has become dead gray. When we look at the 35% of patients, when they get here, either TPA has reopened the vessel or they've clinically improved, and so EVT is not necessary. 15% of the time that clot has moved from one of those large vessels that Dr. Hawks talked about to a more distal vessel that they're not able to retrieve with endovascular therapy. 9% of the time when they've arrived at the Hamilton General and they've had that CT, there's a bleed. Sometimes, 9% of the time, the patient has a large vessel occlusion. They may have a lower NIH, and they're transferred to observe to determine if the patient worsens, will they go in and do endovascular therapy? And sometimes 6% of the time when the patient comes and the interventionalists look at the vessels, realize that it's actually not a new clot, but it's a more chronic clot that the patient may have. I'm going to turn it over to Steph, who's going to talk about what patients receive.
Thanks, Rhonda. So yeah, just a little bit about our patient characteristics and really answering the question, who are we treating? I apologize, I'm not looking at the screen because there's a big screen in front of us, so I'm going to be looking at that screen. But really, if we look into some of the patient characteristics, first looking at age, you can see the average age of the patient that we treat is 72 years old. But I think the thing to really note here is the range of the age of patients that we treat. Patients have gone through Hamilton Health Sciences and been treated with endovascular therapy from as young as 29 up to as old as 99 years old. So really very little in terms of age restriction in the adult population. In terms of site occlusion, we mostly see M1 segments where the occlusion is, and that's the segment that's circled there on the right side of the screen in the picture. Again, we see them about 53% of the time. We do see carotid T occlusions about a quarter of the time. And the other sites of occlusion include M2, vertebral-basilar, and ICAs. As we know, the treatment for hyperacute stroke is not just a choice of only EVT or TPA, but potentially both hyperacute treatment interventions if the patient is an appropriate candidate for both. we're seeing patients treated with TPA in advance of endovascular procedure about 45% of the time. And actually, this number's decreased a little bit over the past year or so, but it's likely because of the number of patients that we're now treating in the expanded window. And we know in the expanded window, those patients would not be eligible for TPA. The majority of cases that we've seen are stable. Almost 90% of the patients undergoing EVT are considered stable, while 10% are considered unstable. So the patients we're treating are presenting with quite devastating strokes. And thanks, Dr. Hawks, for referring to the NIH score and walking through a little bit about what it means. The median admission NIH score for the patients that we're seeing for all our EVT cases is 19. So I wanted to illustrate what that would mean on, or at least look like on a potential NIH score for that patient. So a patient who scores 19 on the NIH, they might present with a complete gaze palsy, completely flaccid upper extremity and completely flaccid lower extremity, severe sensory loss. There may be some mild inattention. The patient may be disoriented. They could present with severe aphasia, a complete facial palsy, and severe dysarthria. So that's the picture, that's the picture of the average patient that's presenting prior to undergoing endovascular therapy. And as you can see, quite devastating impact of the stroke. What we're seeing on discharge is an average NIH score of 4. So an incredible drop from admission score of 19 on the NIH to a score of 4 on discharge. And again, just to highlight what this might look like from the picture that I just presented, this patient might present with some drift in their upper extremity, some mild language difficulties and aphasia, and maybe some partial facial weakness. And that will get a score of 4 on the NIH scale. So you can see the significant reduction in disability post-stroke secondary to the patient undergoing endovascular therapy. A few more detailed components of what we're seeing. We do see that the median length of stay for these patients are 5 days. Again, not a very long stay in this hospital. The majority of these patients are repatriated back to their sending site, and a good proportion of these patients are actually discharged directly home. 21% of patients discharged directly home. 17% of these patients go directly to rehabilitation, while 16% of these patients do not survive their stroke or are discharged to hospice. A couple more slides here. And this is looking at the early window versus the late window. And so you can see we've termed it as non-rapid cases. So that means early window cases in this case, and that's the light blue color. And then red are the late window cases. And you can see quickly by glancing at this chart, the results are very similar in terms of a functional outcome for the patient. And it might seem counterintuitive, but we do know that every second counts, and these patients must get urgent attention. But by using the automated software that Dr. Hawks referred to in Central South Ontario, we can again very appropriately and selectively choose candidates who would likely benefit from endovascular therapy in the expanded window. And so again, those patients who end up going for endovascular therapy in the expanded window, the results are very similar to those in the early window. When comparing these cohorts, you can see their admitting NIH is the same, and their median discharge and NIH is the same as well. Most of these patients can see a change from about 18 all the way down to 4 on discharge. And then just looking at some discharge disposition data, again, comparing the early window, the, again, light blue color versus the late window red color. Again, there are some very mild differences here, but those patients in the late window are most frequently repatriated to their home hospital. 18% of these patients are referred directly to rehabilitation, and 13% of these patients do go directly home. So those are, again, some of the highlights of the data that Rhonda and I wanted to present you from the cases we're seeing here in Central South Ontario. I think the impact of the endovascular therapy program in this region and far broader than this region are clear. This has been an incredibly effective treatment that we're very happy to be able to offer to persons with stroke in Central South Ontario. And very interesting to see Rhonda the slides from before, looking at 2015, looking at 15 or 16 cases, and now projecting our numbers out to be between 155 and 175 cases in a year, and that's continuing to grow as well. So amazing to see this intervention being so prolific within our area. So thank you to everyone involved. We'll open up there for questions with regards to the data.
Were there any questions? I'm not sure if there's any questions in the chat.
Hi, Frank Fernasser here. Just wondering, so we're talking about the delayed, doing the EVT delay. Now, is that already in process? Is that what you're already doing that, and there's established protocol for that?
So we are. So in the late window, so in cases who present within the 6 to 24-hour window, Dr. Oshkowski will talk a little bit more about that, but we started in June of 2000, no, the late window stuff. 2019 with the automated software at the Hamilton General Hospital. We then rolled it across to all 5 of our TPA providers. So Grand River was in July, Greater Niagara was in August, or Guelph General was in early August. Greater Niagara General was in September. Brantford went live in December, and Joseph Brant went live just in January. So since January of 2020, all of our centers who provide and evaluate patients in the hyperacute window do have that. We have also then been implementing protocols because the paramedics will only take patients to those stroke centers within the 6-hour window and are currently not using a tool that will identify patients with a large vessel occlusion in the field. Then what we really are seeing is we then develop protocols so that when patients present at hospitals that are not our stroke centers, so for example, as David flagged with Dunnville, they will screen patients immediately when they come in, and if they have dense symptoms, then we'll identify them as being candidates in the late window, and then we'll transfer them to their closest stroke center for that imaging.
That's fantastic outcomes for sure. So are there plans, I'm assuming there are plans to get the paramedics in the field to be able to identify these patients more readily, as I guess what Dave really talked about earlier in his first talk?
Yeah. So
yeah, you're going to steal my thunder for my talk coming up.
Sorry, Wes.
So currently the paramedics have a prompt card that they have been using for a number of years. What has changed with that prompt card is the time window for when they'll take them to a stroke center. So currently with that prompt card, an onset of symptoms or last known well is within 6 hours. What the paramedics will be using shortly, and when I say shortly, likely within the next 6 months, 3 to 6 months, is they'll be using the Los Angeles motor scale, which is called the LAMS, that when it has a score greater than 4, will identify patients as likely having a large vessel occlusion that can help with that communication. So it's meant to pick up those symptoms in the field and is a bit more specific than to pick up patients with a large vessel occlusion.
Oh, that's fantastic. And I'm sure Wes has got tons of even more fantastic information he's going to pass on later.
Yes, absolutely. Any further questions? So what we'll do now is we'll take a break for 10 minutes until 2:30. Then what we'll do is do a bit of a breakout session from Dr. Hawk's talk. Barb will explain to us how we're going to do that breakout session, because we know some people are in a couple of people, others are alone. So what we'll do is we'll come back at 2:30. You can stay logged in. You don't need to log off and log back in. Just we'll mute your lines and we will reconvene at 2:30.
Could I ask that people send me a quick message if they're in a little group somewhere, and I'll break you out accordingly. My understanding is people are pretty much working on their own, so just send me a quick message in the chat.
Okay, we'll be back at 2:30.
Okay. Rhonda, do we want to check in with Wes and check his presentation, or?
Yes.
I'm ready and good to go, I think.
Okay, I'm guessing you'll just share your screen, Wes?
Yes, I can do that. Yeah.
On